A very good morning to Dr. Zurina and my fellow friends. So today I'm going to explain about the meningitis, which is one of the important infection we can see in a pediatric patient nowadays. Okay, let's start off with the definition of the meningitis. So from the name itself, we know it is an inflammation process that involves the meninges of the meninges. This meninges consists of three layers, which is dura mater, arachnoid and pia mater, and these layers are known to be a protective layer of brain and spinal cord. And more commonly, these meningitis are involved only two layers, which is arachnoid and pia mater, and also known as a leptomeningitis. And of course, when there is an involvement of arachnoid and pia mater, there is an involvement of subarachnoid space that contain the CSF. Okay, next move on to the etiology of meningitis. So for the etiology, we can divide into infectious and non-infectious. For the non-infectious part, we can say the meningitis, they can get the meningitis from the conditions such as autoimmune disease, for example SLE, Kawasaki disease, or can be due to the malignancy, or also can be due to the reaction, body's reaction to the certain drugs such as NSAID, isoniazid. Okay, next we move on to the infectious part. So this can divide into common and uncommon. For the common part, the meningitis can be due to viral or bacterial organism, and for uncommon, it can be due to either fungal or TB meningitis. Okay, for the viral is very common compared to the bacterial meningitis, and it can be due to enterovirus, EBV, HSV, or HIV. And these viral meningitis are usually self-limiting disease and does not lead to any serious complication, unlike the bacterial meningitis. And for the bacterial meningitis, the organism are usually vary according to the age group. For example, if less than 1 month, the most likely organism is E. coli or GBS. And for 1 to 3 months, the most likely organism is strep pneumoniae, GBS, or Haemophilus influenza. And for more than 3 months, the most likely organism is strep pneumoniae, Neisseria, or Haemophilus influenza. And this bacterial meningitis is considered a serious infection because it can lead to complication which can be cerebral or other complications such as septicemia, local vasculitis, and so on. Okay, next let me explain to you all about the pathophysiology of meningitis. Okay, as we all know, the meningitis can be spread via direct or blood hematogenous spread. So the direct spread, it can be due to either there is any anatomical defect or any open basal skull fracture. And for the hematogenous spread, the pathophysiology involves four main processes, which is colonization, invasion, immune evasion, and meningeal invasion. Okay, and usually these hematogenous, the meningitis that happen via the hematogenous spread is usually results from the primary infection, which can be sinusitis, otitis media, or pneumonia. Okay, and this bacteria will have some virulence factor that help them to go through this pathophysiology in order to causing the meningitis. Okay, and for example, we take a nose. Okay, so the lumen of nose being a access point for the, or being the entry point for the bacteria, and then these bacteria have this IgA protease, which is enzyme that help them to break down the IgA mucosal antibody. So when this antibody is break down, so this bacteria will gain easy invasion into the mucosal epithelium and then causing primary infection, which can be sinusitis or pneumonia. And then there are some bacteria such as GBS or strep pneumonia have these polysaccharide capsule which help them to evade through the macrophages or complement factors and then help them to enter into the bloodstream. So then they will travel via the bloodstream and goes into the CNS. Okay, they invade into the CNS and then reside in a subarachnoid space. So when they are at the subarachnoid space, they will be multiply, and in order to respond to the bacteria, in order to respond to the infection, the body will release cytokines which will cause endothelial damage, and in turn this will increase the permeability of blood-brain barrier. When there is an increase in a permeability of blood-brain barrier, this will cause transendothelial migration of the granulocyte and monocyte, and also leakage of plasma protein. So when this occurs, this will cause cerebral edema. Okay, when there is a cerebral edema, this will cause the increase in pressure surrounding the brain, which leads to the raised ICP, and also there will be reduced cerebral blood flow, which can cause cerebral infarction as well. Okay, let me explain how the patient get raised ICP in meningitis. So as I mentioned during the pathophysiology, so the meningitis, when the meningitis occurs, there will be release of cytokines which causing the endothelial damage and then increased permeability of blood-brain barrier. So when this occurs, there will be cerebral edema. So when there is a cerebral edema, this will increase the intracranial pressure as well as reduce the cerebral blood flow. So when the cerebral blood flow is reduced, this can lead to cerebral infarction as well. Move on into the clinical features or clinical presentation of meningitis. So let me explain regarding the symptoms. Okay, for the younger children, usually which cannot explain really their symptoms, so they usually presented with non-specific symptoms such as fever, seizure, irritability, vomiting, or reduced feeding. And for the older children that really can explain their symptoms, they may have the classical triad of meningism, which is a headache, neck stiffness, and photophobia. And also for the symptoms, we can also look for symptoms of raised ICP because it's one of the complication of the meningitis. So see whether the patient have vomiting, headache, or reduced consciousness. And also we can look for symptoms of septicemia as well. For example, the patient have any rashes, fever, or bleeding tendency. Next, we move on to the signs. Okay, for the signs also for the younger children where they cannot really follow our instructions, so it's very difficult to elicit the signs like Kernick or Bodensky. So for them, the most reliable sign is via the neurological examination, we elicit the hyperreflexia, which is suggestive of meningitis. And then for the older children which can really follow the instruction of doctors, so for them we can elicit the signs of meningism, which is Kernick or Bodensky. Okay, let me explain regarding the signs. Okay, for the Kernick sign is basically is a back pain. The patient will feel back pain when there is a extension of the knee from the flexion of the knee and the hip. And the Bodensky sign is basically a passive flexion of the knee and hip when the neck is flexed. And the Kernick sign is basically due to the stretch of the meninge, and the Bodensky is basically due to the meningeal irritation. If the symptoms are suggestive of raised ICP, so we can look for signs of raised ICP as well. For example, we can see whether their anterior fontanelle is full or not, basically for younger children. And even we can do the fundoscopy to elicit the papilloedema. Same goes to the septicemia. If the symptoms are point towards the septicemia, so we can look for signs of septicemia, which can be tachycardia, tachypnea, reduced urine output, prolonged capillary refill time, and also hypotension. Next, we move on to the investigation for the meningitis patient. Okay, it's very important to do the lumbar puncture because it's a definitive investigation for meningitis. So this lumbar puncture is involving the process where we obtain the CSF to confirm the diagnosis, and also we send for the biochemistry test where we look for cell count, protein, glucose, and so on. This is in order to differentiate between the meningitis, whether it can due to the bacterial, viral, tuberculous, or fungal, and also in order to provide the patient with a correct management. Okay, and then this lumbar puncture is basically must done to the patient who having fever and also sign and symptoms of meningitis. But there are some conditions where the lumbar puncture is contraindicated. For example, if patient is hemodynamically unstable, or patient having signs of raised ICP, or patient is having some local infection at the site of LP. So these are the conditions where the lumbar puncture is contraindicated. Okay, next is also very important to do a blood test and also a culture and sensitivity test for the meningitis patient. Blood test involves starting with full blood count, where we can look for evidence of infection such as leukocytosis, and also we can look for any lymphocytosis or neutrophilia in order to differentiate between whether it is suggestive of viral or bacterial infection. Apart from full blood count, we can also do the C-reactive protein test or the erythrocyte sedimentation rate test in order to see whether there is ongoing active inflammation or infection. Next, we can do urine FEME in order to rule out urinary tract infection. We can also do a renal profile in order to see whether patient is in dehydration or not, or there is any electrolyte imbalance as well. And then last but not least, for a part of a blood test, we can do a blood culture and sensitivity to identify the organism in order to provide the patient with a correct management which involves the antibiotics. Okay. And for the meningitis patient, it's very uncommon to proceed with imaging, but the imaging for the meningitis patient is indicated or necessary if the patient having prolonged seizure. This is because we have to do a CT or MRI of brain to rule out other causes of prolonged seizure, or if the patient's head circumference is keep increasing, so where we suspect the subdural effusion, so where we can do the imaging such as CT brain or MRI brain to rule out subdural effusion. And this is where the imaging plays a role in meningitis patient. Next, we move on into the how we manage the meningitis patient. Okay, it basically involves three concepts, which is medical management, supportive management, and also long-term follow-up. For medical management, it's very important to give antibiotics for the meningitis patient and also consider a definitive treatment for meningitis patient. But there are some factors we have to take into consideration when we're giving the antibiotics, which is age group and also duration of the therapy. For example, we take the less than 1 month, so most likely organism is GBS and E. coli. Okay, for instance, we take the culture and sensitivity test results comes out as a E. coli meningitis, so we can give C penicillin plus ceftazine for 21 days at least, because it is a gram-negative bacteria. Okay, so this is where the age group and also the most likely organism plays a role when giving the antibiotic, because it varies in terms of duration of therapy. And also there are some evidence that suggests that steroid use is effective in terms of reduce the complication of bacterial meningitis, but basically it's best effect when the steroid is given before or with the first antibiotic dose. Okay, and next, for the supportive management, it involves three main points, which is monitoring, fluid management, and NBM. Okay, for the monitoring for the meningitis patient, since we admit them into the hospital, so we have to monitor their vital signs, IO chart for hourly, and also we have to put them on seizure chart and also do a daily CNS assessment as well. And also we have to monitor their head circumference regularly, because if there is an increase in the head circumference, we have to suspect patient either having subdural effusion or hydrocephalus. Next, for the fluid management, is very important to careful fluid balance. Usually a maintenance IV fluid is sufficient. Okay, and then if the patient is dehydrated, a patient may need more fluid. And then if the patient is having signs and symptoms of raised ICP, okay, and during first 18 to 24 hours a cerebral protection or cerebral resuscitation is required in order to prevent the cerebral infarction, and 30-degree bed aid elevation is required as well. And then we can use IV mannitol judiciously in order to prevent acute renal failure and also reduce the cerebral edema and also ICP as well. If the patient is having fever, we can give them antipyretic agent as well. Last but not least, a long-term follow-up is required for the meningitis patient, especially in order to assess the development of the child at home or in school, and also to assess or to keep track the head circumference, whether it is normal or abnormal, and also to assess vision, hearing, and speech. So for the meningitis patient, it's very important for them to be in a long-term follow-up, especially in order to assess their development and also to assess their recovery from the meningitis. Okay, last but not least, let me explain briefly about the complication of meningitis. So as basically we can divide into cerebral and extracerebral. For the cerebral complication, the patient may have cerebral infarction due to the reduced cerebral blood flow, and this cerebral infarction also can lead to focal or multifocal seizure as well. And then patient also may have subdural effusion. Basically, it is associated with Haemophilus influenza or pneumococcal meningitis, but this condition is nowadays uncommon due to the introduction of the vaccine. Next, the patient is also may have hydrocephalus, usually due to the impaired resorption of the CSF. So the patient may have communicating hydrocephalus as well. Last, for the cerebral complication, the patient may have cerebral abscess, especially if the patient's condition is deteriorated, temperature is fluctuate, and there is a signs of the space occupying lesion. So we have to consider a cerebral abscess, and immediate abscess drainage is required for this patient. And then for extracerebral complication, the patient with meningitis may have hearing loss, basically due to the damage to the cochlear hair cells, or the patient may have local vasculitis, which may result in cranial nerve palsy as well. So it's very important for the meningitis patient to have a regular hearing assessment in order to see whether the patient is having hearing impairment or not. To know more about the pathophysiology of the bacterial meningitis, you can click on the link at the description below. And hope you all enjoy my video today and know a bit about the meningitis now. And once again, thank you everyone for the attention and good luck.